So today we're going to talk about lateral epicondylitis or tennis elbow. So just a brief overview of the anatomy. You have your humerus, your radius, your ulna. This little bump here at the edge would be considered your lateral epicondyle, which is not to be confused with this bumpy part of your elbow, which is the olecranon process of your ulna. And then going through the muscles, you have your brachioradialis, which sort of separates the front compartment from the back compartment, going from medial to lateral, going from inside to out. Number one is extensor carpi radialis longus. The one in orange, which is the one that often is most implicated, would be extensor carpi radialis brevis. You have extensor digitorum, and then extensor carpi ulnaris. Looking at epidemiology, it's considered an overuse injury. Don't necessarily agree with that. Most people will have issues in some form of extension in either pronation or supination. 20% of cases last up to a year. In most cases, it's up to 2 years. So if you did absolutely nothing or minimal effective treatment, you'd end up about 2 years, and even then the symptoms still may not go away. Clinically, it'll present with pain at the lateral epicondyle. It occasionally radiates up and down the arm, and this can sometimes show up as cervical radiculopathy, so it's just something to kind of keep in mind. And the last one is you usually get pain after some type of provoking activity. Again, some combination of extension with pronation or supination. Is it coming from the neck? So basically, is it cervical radiculopathy? And so some of the things you may find is plus minus. So you may not find it. Some type of change in reflexes, a myotoma distribution of symptoms. So let's say they have weakness coming from C7, so you're more likely to experience weakness in elbow extension. So those two things typically correspond. They may have headaches or frequent headaches. They may get some type of paresthesia or numbness. But probably the biggest thing you're going to notice is they're going to have reduced cervical or neck range of motion that sort of coincides with the fact that they're getting sort of this weakness and numbness going down into their arm as well. So before we continue as to what I would do and what I think is actually happening and how to manage lateral epicondylitis or tennis elbow, is a little bit more anatomy. So most professionals have seen some format of this. Excuse the crudity of the drawing. It's not exactly to scale. But you have a tendon, which then connects to and blends out into an epimysium, which then kind of further, when you go deeper through there, you end up into the paramysium. So all of these muscle fibers get bundled together. So these bundles all sort of branch out individually as you go deeper into the endomysium. And so this makes up one muscle fiber or fascicle. And within each fiber, you have myofibrils, which make up the actual muscle. When we think about a problem like lateral epicondylitis, we, as most professionals, will look at it like we have bone, we have tendon, and then we have muscle. And that's the way it's kind of drawn in most of our textbooks. So that would be considered more of an in parallel, that there is a delineation. But for most healthcare professionals in allied healthcare, we've gone through cadavers and looked at a sea of gray. It just all looks the same. It just is like mush, right? So to say, I can take a bone and then I can delineate between where the tendon stops and begins, where does muscle start and begin. It's up to an anatomist who uses a scalpel to cut that, right? The reality of things is that everything is together and that it's in series. So they all sort of blend into each other. So bone and tendon, as they come together, it sort of blends together. And then often the tendon will start blending with the muscle. This is most seen, let's say, at your calf, right? So with your Achilles, you can feel really tendony stuff. And then as you go up into your calf, it sort of turns into just calf muscle. But there's a brief point where you can feel sort of that change between the two sort of fiber types. But what is interesting to me is going back to this, again, I'm sorry about the drawing. I will work on that. What makes up all the red stuff's muscle, but what fills all this space here, all this white stuff behind it, all of that is connective tissue. And so to say that all of this space that runs here and here and here, as you go deeper, it's all connective tissue. And so if you think about anatomy as one blend of tissue, one flow of tissue. Everything that is in between all of this is connective tissue. And this is primarily a connective tissue problem. So how would I go about managing this? First, does the joint move how it's supposed to? So what joints involved? The elbow, the wrist, and I would also look at the shoulder, depending on what their activity, what they're doing. So someone that plays tennis, I'm gonna look at your shoulder. Pickleball, I'll look at your shoulder. If you work at a desk or you're an artist and you don't do any of those other types of shoulder-based activities, I'm probably still looking at your shoulder, but I'm not likely to think that it's coming from here. But again, I'll still look at it. So with the elbow, does it pronate? Meaning, does it get all the way over without getting maybe here and saying, oh, I need to kick my arm out and now I'm flat. But you didn't really get there because you needed your shoulder to get there. Same thing for supination. Does it supinate? Are you parallel to the ceiling and sky? Then I would look at wrist extension and wrist flexion. Are you able to get those? If it doesn't, stop, fix that first. And there's others, you can't load unless it moves how it's supposed to. In fact, I probably would use this the most to help get that to be where I need it to be. Second, let's say the joint, you get pronation, supination. Is the joint mad at me? Is that area of my body mad at me? So meaning, if I look at it the wrong way, it gets irritated and now it starts being painful and uncomfortable. If that happens, stop, you gotta let it rest. Can you load it? Under the right supervision, yes. But if you're doing this on your own, let it rest till it's not mad, right? You gotta be able to grip a little bit. You gotta be able to do something before you start loading it. Because if you try to just load it and it's mad at you, it's not gonna take much to irritate it again, and then you're kind of back at square one. So you gotta let it calm down before we build it back up. Last, progressive load. Starting with the least neurologically demanding to the hardest. Start with an iso. As that gets comfortable, you can move into an eccentric motion. As that is tolerated, full range of motion, maybe combining of joint motion. So it wouldn't just be pronation, supination, flexion, extension, adding some sort of wrist deviation as well. Lastly, some type of speed. Again, this is all based on what you need. So if I'm playing tennis, if I'm throwing a baseball, pickleball, you're probably gonna need this, right? Some element of being able to stress stiffen, speed strength, being able to tolerate those type of loads. If I'm just an office worker, if I got this from gardening, probably won't need this as much. It's a little important, but I probably would stop right around here. Again, depends on need. If you have any questions, let me know. If you like this and you'd like me to do more, let me know in the comments and be happy to break down something else, what we traditionally see, and then what I would do. One final point about lateral epicondylitis or tennis elbow, which I realized after the fact, I could have spent maybe a minute or two discussing. Didn't really want to draw another figure out. So if we think about the length tension curve of a muscle, we know that most muscles like to operate in sort of that bell curve shape, which is the middle. So that, if you impose that onto, let's say, a joint's full range of motion, does not constitute the full range of motion in terms of what you feel. So if you think about a bicep being all the way flexed, the length tension curve, let's say that's the bottom, right? There's no length and no tension. As I'm coming out, it starts going up. But as I reach the end, the biceps length tension, this muscle comes back down that curve. And so what takes up the slack? What is the stress that you feel, the stretch that you feel? If we put the stress strain curve superimposed onto a length tension, so you should know that a length tension is a bell curve shape. The stress strain curve has a 1-to-1 slope. So it kind of goes up. For every one that it goes right, it goes up one, so on and so forth all the way, up until you hit the failure point, and then it comes back down, and that's usually where injury occurs. And so if we superimpose that, and we know that the length of a muscle will eventually stop toward that tail end, what takes up the rest of that slack? Well, it's your connective tissue. And this is why so much of the tendon protocols that you see out there are focused on eccentric work. It's because you're moving at length to end range, and that's how you preferentially bias that. One other thing that I won't get into here is tissue architecture. So when there is some type of tendinopathy, there is almost always some form of dysfunctional tissue architecture, and whether it's skeletal muscle tissue, whether it's connective tissue, it's a little bit of, usually it's all of the above. There is some type of disconnect between how you're training and then how you're using said joint that has now caused sort of an imbalance in towards one type of architecture type, and it's missing the other. So I hope that clears up a little bit more what we're trying to do when it comes to lateral epicondylitis. Like I mentioned at the end of the last shot, if you enjoyed this, if you would like to see me kind of break down more stuff or talk about any of this, drop a comment, send me a message, let me know, and I'll see you around next time.